Welcome to Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. Today, we'll narrow down the spectrum of rumors around antimicrobial stewardship.
Steve, there are some days I just wonder, are we dispensing antibiotics based on the patient or just broad spectrum vibes?
Yes, the feels bacterial vibe. I know exactly what you mean. But when does it just become antibiotic astrology at that point, Don?
Antibiotic astrology, I knew you'd come up with something. The pills in our stars, right? You might be onto a new field there, Steve.
Yikes. Let's hope, Don, that doesn't become an idea that's infectious and spread. And before Don comes up with more ideas, I'm Steve the pharmacist.
And I'm Don, the pharmacist.
And in this episode, we're looking at antimicrobial stewardship because the best antibiotic decision isn't always the strongest one. And the wrong one we know can cause harm long after the infection is gone.
Right, so it's antibiotic that stays in the right orbit, which is most likely to help, least likely to harm, and least likely to create downstream problems. And in terms of CE, this podcast offers continuing education credit for pharmacists, pharmacy technicians, prescribers, and nurses.
Yeah, just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast and the list of available CE courses.
And for the purposes of disclosure, our guest, Dr. Madeline King, reports a relevant financial relationship with Shionogi by serving on the Speaker's Bureau for Cephalosporins. The other speakers have nothing to disclose. All relevant financial relationships have been mitigated. All right, let's get down to it. So, no, antibiotics are the most common and most consequential meds we use. When the right drug meets the right bug, it can be life-saving.
Yeah, and there's a common thought here that antibiotics are low risk, and if they're not needed, then they're not harmful. But they're one of the fastest ways to create avoidable harm when we use them for the wrong indication, the wrong duration, or the wrong route.
Yeah. Patient perceptions play a role here too, right? Some prescribers fear that not prescribing antibiotics lowers patient satisfaction, but withholding or deprescribing antibiotics if they're not needed might actually be the best course in many cases. A good example is watchful waiting, where we start antibiotics only if a patient worsens or doesn't improve in a few days. We see this with sinusitis and ear infections, which more often than not are caused by viruses.
Yeah, it's a great strategy. And stewardship isn't necessarily just no antibiotics, right? It's
Mm,
also using the right antibiotic at the right dose, right duration for the right patient, plus reassessing as new information comes in.
correct, Mr. Wright. So let's go ahead and jump into that first claim, right? So, the big picture claim that I've heard from some colleagues, and it may sound a tad gram negative, it is stewardship isn't reducing overall antibiotic resistance.
Oh boy, that is cynical, Don. And that's coming from me saying that.
I know, yeah, it's a big shock there. So I'm surprised I haven't heard this claim from you yet, Steve. Right, but I could see where the sentiment may come from. Resistance is a major global problem, and we'll always be dealing with resistance since it is a natural phenomenon. It's due to natural selection, after all. So naturally, it can feel a little daunting.
And we do need to face the fact that resistance has indeed worsened in the 2020s. But CDC attributes this to the COVID 19 pandemic derailing a lot of prior progress, like it derailed a lot of things. In fact, in December 2019, CDC actually reported that some resistant infections decreased throughout the 2010s in the US, likely due to improved stewardship. For example, vancomycin resistant enterococci infections decreased by 41%, and multi drug resistant pseudomonas decreased by 29%.
All right. So what you're saying really is stewardship can work, right? But implementing these practices can be difficult depending on the setting, especially if you're working in a community pharmacy or a clinic.
Yeah, that's a good point. Working in the hospital, I was lucky to have an entire infectious diseases team literally on speed dial to help us use antibiotics appropriately. And that luxury is rare in the community pharmacy setting. But you'd be surprised what community pharmacies can do in terms of stewardship.
Mhm. Plus, stewardship also isn't just about resistance in the abstract. It's patient safety, so more concrete, right? So fewer adverse effects like GI upsets, fewer drug interactions, fewer C. difficile cases, fewer patient costs, and fewer complications from throwing the kitchen sink at an infection.
I totally agree. And stewardship isn't just one single intervention, it's a bundle. Verifying indication, choosing the narrowest effective option, setting a stop time, and even converting to oral from IV antibiotics when appropriate. And of course, reassessing the patient.
Right. All good points. So let's go ahead and go back to that claim, which is stewardship isn't reducing overall antibiotic resistance. And the verdict is rumor.
I think the mistake is expecting stewardship to just solve global resistance overnight. It's really about harm reduction. Fewer unnecessary antibiotic days equals less selective pressure on that bacteria and less harm.
All right. Not for the immediate gratification crowd, right? When it comes to that. So let's pause here. So we should also keep in mind that stewardship isn't just about antimicrobials that target bacteria. It's also important for antifungals, antiparasitics, and antivirals too. They do not get a free pass on this.
Yeah, accounting for the whole microbial kingdom, they're done.
Yep.
They're equally important as well.
Mhm. And if stewardship seems daunting, we advise starting with small steps that apply to both community and hospital settings. That can make a big difference. For example, ensuring every antibiotic order has an appropriate indication and a planned duration or stop time. If either is missing, that is a fixable problem.
And there are tons of opportunities to help improve antimicrobial use, including in community pharmacies. So find strategies using our antimicrobial stewardship toolbox, which also features links to many infectious disease resources.
Yeah. And talking about resources, here's something to make your professional life easier.
You betcha. Not subscribed yet or thinking about upgrading? Access more trusted clinical insights and save 10% with our exclusive listener promo code RVT1026 at checkout.
Details and links are in the show notes, so don't miss out.
And you know, Don, I'm glad you mentioned antibiotic stop times just a moment ago as a good quick intervention. There are so many different infections out there. It can be really tricky to keep optimal therapy duration straight. So, one interesting claim I recently heard is most outpatient infections only need 5 days of antibiotics.
Sounds simple, 5 days, right? Or is it simply too good to be true?
Exactly what I was thinking. So, to help us with this claim, I reached out to Dr. Madeline King, PharmD. She's a board certified infectious diseases pharmacist and is the co director of outpatient antimicrobial stewardship at Cooper University Healthcare in Camden, New Jersey. And you may recognize her from the recent stewardship episode of our sister podcast, Medication Talk, back in March 2026. Let's see what she had to say on this. Thank you for joining us, Dr. King, for this question. I'm really curious, what is your take on this claim that most outpatient infections only need 5 days of antibiotics? I'm sure a lot of audience members are thinking, boy, that's pretty short.
Yeah, thanks for having me. And I think it's a great question. Um, I think it really depends on the infection type. But for the most part, yes, a short course of antibiotics is appropriate for most things that we see in the outpatient setting. Upper respiratory tract infections, urinary tract infections, things that are pretty mild to moderate is where we would think about shortening the course.
Great. Are there any exceptions to maybe point out that you see in practice that maybe the 5 day rule doesn't fit?
Yeah, I would say, 5 days is pretty appropriate for most upper respiratory tract infections, UTIs, even shorter, 3 days for some things. There's a few exceptions in these mild to moderate outpatient infections where you might treat for 7 days. So something like pyelonephritis, so more complicated UTI essentially, or for sinusitis or pharyngitis, there is some data to suggest that 7 and up to 10 days, depending on the specific infection and what antibiotics you're using to treat it, might be more appropriate.
That's great. And I'm sure a lot of folks are wondering, does using a shorter course potentially worsen outcomes? For example, do infections, are they more likely to come back? I'm sure people are worrying about that.
Yeah, it's also a great question. I mean, nobody wants to take antibiotics and then have a recurrence of their infection, right? So, what we found, there's a lot of literature now, which there really wasn't 20, 30 years ago, showing that shorter versus longer courses, when compared in clinical studies, shorter courses are typically fine for most of these mild to moderate infections. Like I said, there's obviously some exceptions when we're talking about patients with bone infections, definitely not that short. We're talking weeks.
Right.
But with these mild to moderate things that are just concerning skin and soft tissue, the lower urinary tract, and kind of mild respiratory tract infections, we don't see worse outcomes when we give shorter courses.
Well, that is reassuring. And I'm looking forward to bringing this back to Don and see what he thinks. And thank you so much for helping us with this claim.
Yeah, thank you so much.
Okay, wow, she really had some great points there. And regarding those upper respiratory infections or URIs, the short duration is only if the infection is actually bacterial, right? In most cases, as we know, aren't. And Steve, you cheater, don't think I didn't hear you on that medication talk episode, but don't worry, no adverse reactions here.
Dawn, it's not you, it's stewardship. I'm just going where the topic leads me. But seriously, here, if you're a pharmacist or a tech, the length of therapy is a great place to intervene on a prescription. Look for prolonged durations and help clarify them at the point of dispensing, especially when the quantity doesn't match typical guideline durations. And if you're a prescriber, keep indications in mind that only need typically 5 days of treatment and help educate your colleagues. So, when it comes to this claim that most outpatient infections only need 5 days of antibiotics, the verdict is true.
Okay. So, important thing to remember, this claim is that most outpatient infections only need 5 days. And what I like about this too is that 5 days is such easy to remember, right? I'm counting pills in fives, after all.
Yep, pretty convenient. And I like that caveat you made, Don. Be aware that there may be times patients need longer therapy, so we need to be ready to tailor durations. For instance, patients discharged from the hospital for a more severe infection, they need 7 days of antibiotics instead of five.
Right. On the exception train here, watch for other exceptions to any longer therapy, such as strep throat, right? Or infections in kids younger than 2 years old. We do have our resource antibiotic therapy when our shorter course is better chart as a quick guide on optimal durations.
Yeah. Speaking of quick guides, before we dive into our other claims, how about we do some stewardship fast facts?
This is where we jump into some common bite sized claims about stewardship and give them our seal of approval or debunk them quickly.
Okay, here we go. The first one is asymptomatic bacteria ASB shouldn't be treated with antibiotics. Now, this one is true with conditions. In most non pregnant patients with bacteria in their urine but without symptoms, antibiotics provide no benefit and can actually cause harm, things like side effects, resistance from that unnecessary exposure.
In fact, evidence shows that using antibiotics for ASB actually increases your risk of UTIs in the future. You might be thinking that's weird, right? Well, studies show that in women with recurrent UTIs, the bacteria hanging out in the bladder without causing symptoms are actually protecting against more pathogenic bacteria. So it's like your bladder's own bouncer, right? Treat with antibiotics and you're in trouble. Sort of bitter irony there.
But there are important exceptions to remember here. Pregnant patients and certain urologic procedures, those patients actually do benefit from ASB treatment, so keep that in mind.
Right. So, review more tips on ASB in pregnancy and UTIs in general using our urinary tract infections chart. We also focus on fetal safety in our antibiotics in pregnancy and lactations resource. All right. Next up, another common claim we hear is that most penicillin allergic patients can use cephalosporins.
Now, remember, cephalosporins include our ceph antibiotics. Think
Mhm.
cephalexin, cefazolin, ceftriaxone. The list really goes on and on.
Right. So, this claim is also true with conditions, but 90% of reported penicillin allergies aren't really true reactions. And cross activity depends on the chemical side chain similarity, not just cephalosporins as a whole class.
And you can use our managing beta-lactam allergies and our investigating possible drug allergy resources to help you sort out whether a reported allergy is the real deal before moving to alternative antibiotics that may be riskier. Well, that was fun, but let's slow it down for our remaining claims here, Don.
I agree with that. All right. So, next slow claim would be it's one I bet you still hear a lot in the patient side, Steve, and it is IV antibiotics are better than oral options.
Yes, oh boy, we hear this all the time, Don. You're totally right.
Mhm. So now we know that IV antibiotics can be necessary, especially if someone can't take oral meds, is unstable, or there's no reliable oral option.
Right, but for many infections, once the patient is clinically improving and can take oral meds, properly selected oral therapy can
Mhm.
perform just as well. Route doesn't automatically equal
Mhm.
more effective here.
Right. There's a lot of things to consider too, such as whether the antibiotic gets to the infection site. And also think about absorption. Some antibiotics are very well absorbed in the GI tract. Linezolid, for example, has nearly 100% oral bioavailability, meaning oral and IV achieve virtually identical blood levels. Quinolones like levofloxacin aren't really far behind that. And we're moving to oral therapy more for certain infections, right?
Yeah, you're absolutely right. A good example here is gram negative bacteremia or having certain bacteria such as E. coli in your blood. We used to treat this with a couple weeks of IV antibiotics in the hospital, but now evidence supports considering early step down to oral
Mhm.
antibiotics in certain uncomplicated patients.
Mm.
And when we look at studies, they suggest this doesn't appear to worsen important outcomes such as mortality and infection relapse or reinfection.
Right. I love having a hospital dude on with this. So, another one for you is what are some complications with IV therapy?
Yeah, we have to weigh those risks too. We know IV therapy brings its own risks that we need to avoid if we can.
Mhm.
Things like Lyme complications. It also requires more monitoring. It's also more costly and potentially longer length of stay. Those are some things that come to my mind, which is why IV to PO conversions is such a common stewardship focus in the hospital.
Great. All right, so let's go ahead and go back to that claim, which is IV antibiotics are better than oral options. And the verdict is rumor.
Yeah, so don't assume just because something is IV that it's automatically better for an infection.
Mhm.
Oral antibiotics may be more appropriate in many cases, both clinically and also economically, to be honest.
Right, and to pitch another one of our resources, we have our considerations for IV to PO conversion chart to help you decide when and what to switch to if a patient is on IV antibiotics.
And now, with that in mind, let's convert over to our next and last claim here. And I feel like this one is spread faster than, frankly, well, resistance. It's that bactericidal antibiotics are better than bacteriostatic ones.
Okay, let's hold the phone here for a second. Let's break down cidal versus static antibiotics for our listeners.
Yes, you bet. So,
Mm,
bactericidal antibiotics kill bacteria outright. These include
mm,
beta-lactams like penicillins and cephalosporins, quinolones such as levofloxacin, and aminoglycosides like gentamicin.
mm.
But on the other hand, bacteriostatic ones inhibit growth. So, our thinking is the immune system that needs to do the rest of the job of actually killing the pathogen.
All right, so thinking back to my infectious diseases days as a student and as a resident, but uh, and static antibiotics, I think of wrong are linezolid, right?
Yep.
Trimethoprim, sulfamethoxazole, and tetracyclines such as doxycycline, right?
Yep, those are all classic. And there are even
Mm,
some antibiotics where we think they may even do both, such as rifampin,
mm,
kind of interesting. But keep in mind, these designations are only based on lab data from growth
mm.
in test tubes. So it's really hard to translate the cytostatic approach to how these antibiotics work in the human body, which then makes it hard to even extrapolate this to patient outcomes for that matter.
Right. And actually, growing evidence suggests bacteriostatic antibiotics are generally no better or worse than bactericidal ones for many infections.
Right. Let's go back to linezolid you mentioned as an example.
Mhm.
Evidence supports that this bacteriostatic option is no better or worse, at treating pneumonia or skin and soft tissue infections
Mm.
compared to vancomycin, a very commonly used bactericidal IV option we use all the time in the hospital. And this is also seen with linezolid in certain bloodstream infections too, where bactericidal agents have been historically preferred to rapidly kill bacteria. So, pretty interesting there. So, with that, when it comes to this claim that bactericidal antibiotics are better than bacteriostatic ones, the verdict is rumor.
All right, so maybe the goal isn't to find an antibiotic with the license to kill. Sometimes putting the bacteria growth on pause is plenty in some cases.
I agree, especially when we're talking about mild to moderate infections. So, rather than hinging your antibiotic choice on cytal versus static, focus on what actually changes outcomes first.
So think about susceptibility and spectrum, dosing, site penetration, and also patient specific factors like think of like age, weight, organ function, kidney, liver, how are those doing, right? That can impact drug choice and dosing.
And of course, we can't forget adverse effects, interactions, and even just
Mm.
feasibility of giving the med. Plus, within cytal drugs, performance can actually differ by bug and situation. So, this cytal static label should not do the clinical thinking for you. So, with that, the bottom line truth here today is don't let habits and dogmas make antibiotic decisions for you. You got to tailor choices using the right drug, right route, right dose, right duration for the right patient based on good evidence.
And don't think of stewardship as being the antibiotic police. It is a safety process. Antibiotics are powerful tools, and stewardship is how we use that power responsibly without overtreating, undertreating, or defaulting to outdated habits.
I like that, Don. And if you take one thing from today, avoid autopilot prescribing and dispensing. Build in a pause to think about the indication, duration, route, and you'll prevent harm while still treating infections effectively.
Right, great point. So, before you go, claim CE credit and access evidence based resources from pharmacist letter, pharmacy technician's letter, or prescriber insights.
And if you're not yet a subscriber or you just want to upgrade, you can save 10% with our exclusive listener code RVT1026 at checkout. And there's an easy link in the show notes.
And are you a subscriber? Keep those good times rolling and tap the claim credit link in the show notes or search your CE organizer for this episode. And now, before we officially sign off, we got time for one quick follow up from last episode, our Rumor versus Truth mailbag.
Great point. This one came in after our AI episode, and it's an important
Mm.
privacy question. They ask, does AI actually protect patient health info? Now, to help answer this, I was able to bring back our informatics expert, Dr. John Turtle, PharmD MBA, from our prior AI episode. So let's see what he had to say on this. John, welcome back. Glad you could join us again. I'm glad you can help us out with a follow up question from one of our audience members. It's that they're questioning, does AI protect patient health information? What's your take on this?
This one is a bit mixed, Stephen. So, as as a clinician working with certified healthcare technology, there's a thing in our country. This is what they don't teach us in pharmacy school, Stephen. There's a thing called the Office of the National Coordinator that certifies healthcare technology.
Hmm.
And so, if you're a clinician working within an EMR, any of the big EMRs, they have to go through a rigorous process of credentialing. That information there are plenty of AI tools embedded within those systems that we use on a daily basis, either knowingly or not knowingly. All of that information is 100% safe, compliant, no risks, all of that stuff. Where we get into some muddy water are, in the last 10 to 15 years, patient health applications. Anything that's
Hmm.
outside of patient care that patients are willingly putting their information into, that is beyond the scope of really professional practice a lot of the times, and also out of the scope of the walls of what we can provide. So, as far as patient information, a lot of that is just platform. Yeah, I can't just blanketly make a statement that says yes or no to that.
Right.
Um, I will say AI does have a lot of tools when you get into working with data sets to de-identify information and encrypt information automatically. But without knowing more context, it's a mixed answer.
Yeah, that's a great point. And how do we make sure patient info stays protected as we use AI more in practice? Any tips there?
Well, I mean, stick with applications that are uh, recognized and certified by either the organization or have gone through some sort of vetting process. I know there's URAC, which is an accrediting agency that stands for Utilization Review Accreditation Commission. Excuse me. They have just released recently a process of qualifying AI tools that clinicians use, and so I'm excited to see where their scope goes because it's an incredible organization that I'm looking forward to. If you're seeing like a URAC stamp on any sort of technology, and then like I said, the Office of the National Coordinator also certifies applications. So yeah, I mean, this is a a budding field that's growing leaps and bounds. But by the time I talk to you next time, everything will have changed. But those are my immediate answers with patient health information. I would be very wary.
Yeah, great caveats there and good things to look out for, seals of approval and things like that. So thank you so much, John. Good to see you again.
Of course.
It's good to see Dr. Turtle again, and I like his points once again. Patient privacy is everyone's responsibility, so we need to make sure we use these AI programs carefully.
Exactly. And always follow your organization's policies for protected health information. If you're not sure what's allowed, ask before you paste anything sensitive into any tool.
Yeah, definitely. But there's no need to keep your questions private for our next show. If you like our stewardship question about this episode answered next month, send us a message. Feel free to keep it broad.
Good one, Don. And we also use your suggestions to plan our episodes. Email us at rumorversus.truth@trchealthcare.com or the send us fan mail link right from the podcast show notes. And now you can leave us a voice message, and we'd love to actually hear from you. So join us next time where we'll tackle gossip around gabapentin.
Yeah, and have a good discussion about neuropathic pain if we have the nerve for it. So thank you for joining us on Rumors is Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. See y'all next time.